adjustment in the dosage in patients with renal disease, chronic renal disease. And the one that are important for us are antimicrobials or anti-infectives, analgesics. These are the two main classes that we should be aware of. And just one CNS drug, but that is a contraindication. So, anyways, we'll just mention it here. So, here we are talking about chronic renal disease. So, among all the antimicrobials, there are 5 drugs that requires adjustment in dosage in these patients, and they are Amox, cephalexin, fluconazole, acyclovir, and tetracycline. So these 5 drugs, we need to adjust the dose in renal patients. And the adjustment is made as such. So the dosage is reduced, and these are I think there is some problem with the mic. In analgesics, we need adjustments with aspirin, celecoxib. It's of not much use for us. Codeine, most important. Pyridine, and 2 more drugs here, tramadol and gabapentin. And the adjustment are made as such. So dose is reduced to 50%, and coxibs should be avoided in patients with GFR less than 30 milliliter per minute. This is the filtration rate. Codeine dose should be 75%, and meperidine is also 75. And these are given 6 to 12 hours in the interval of 6 to 12 hours. And gabapentin dose is reduced to. So these are the adjustments that are made. Doctor, could you please unmute your mic? Not sure whose mic is unmuted. Okay. So this is all about drug adjustment. So let's talk about drug interactions now, and we will start with cytochrome P450. So when we talk about drug interaction, so these interactions could be either related to the pharmacokinetics or pharmacodynamics. So, and drug interactions are not necessarily considered bad, or they are not always the side effect or bad effects of the drug. So, if we talk about dynamics, then interactions between drugs could be of three types: additive, synergistic, and opposite effects or antagonistic. So, this talks about the net result of the interaction. The effect could be more, the effect could be better, or effect could be opposite. So these are three classifications of drug interactions, and this is talking about the dynamics. When we look into kinetics, so the drug is apparently, and the interactions that can happen could be at any steps. And we know in kinetics, the steps that we discussed are absorption, and the third step is distribution, and last is excretion. So two drugs or any drug can affect the any of these steps of any other drug, and we can classify the drug interactions on this basis also, where they are interacting or changing it, or concentration or levels. So when we say absorption, we talk mainly about oral drugs, or if we talk about drugs that are given IV, we are mainly talking about plasma binding. So first, absorption. Each other during the absorption phase is mostly dependent on the gastric emptying. So there are certain drugs that increases the activity of intestine, or they increases the constriction in the smooth muscles. And increasing constriction means there will be faster gastric emptying, and when the emptying is faster, the body or intestine has less time to absorb the drugs that is present there in the, or the drugs that are taken orally. Then the other type of drug interaction seen during absorption is the binding. When we talk about binding, it could be, the example that we see is chelation, which is seen with tetracyclines. So there are certain drugs that can make chelating compounds in presence of certain ions. So if this type of interaction happens, this is happening at the stage of absorption, and these chelates are not easy for the body to absorb. So this is how it is affecting the levels of the drug. And the other possible way of interaction during this stage can be a transport system. So some drugs are administered in such a way or in a form with a transport system that could be physical or could be chemical. Example, if you remember when we discussed in patients with Parkinson's, the thing that we need is dopamine. But if we give dopamine directly to the patient orally, then the MAO inhibitors, the oxidase enzymes that is eating up the dopamine, is present in liver also, liver, lung, and other organs. So they're gonna destroy this. So substitute is given, that is L-DOPA, which is the precursor of dopamine, with a transport system. Another chemical substance is given with L-DOPA, and this decreases the eating up of this L-DOPA by MAO inhibitors, or I'm sorry, by MAO enzyme or COMT enzyme. So this is an example of transport system. But here we have to remember chelates because we get questions on tetracycline. So this is level one or the step one. A drug goes through absorption. The second step is metabolism that we will discuss in the end. Step number three is distribution. When the drug is being metabolized, mainly by the liver, it gets distributed via blood. When the drug is in the blood, its efficacy towards binding with the proteins is the main dependent on it's the main factor that determines whether the drug is going to be available for absorption or its action or no. So certain drugs, they either increases the binding or decreases the binding. So for example, a patient taking phenytoin. So phenytoin is given in a patient for epilepsy, and suddenly patient has some other condition and the doctor tells, okay, you have to take diazepam for your condition. So normally when the patient is taking phenytoin, I'm giving a number here, 10 molecules of phenytoin is present in the blood and they are protein bound. But if the patient starts taking diazepam, so diazepam has a potential of displacing this bound drug. I don't know why, but there is lag today with my stylus. So, phenytoin is traveling in the blood with the protein molecule, and the diazepam it comes and it competitively, or we can say it displaces the phenytoin molecule from those protein, and diazepam goes and bind to the protein, which results in increased levels of phenytoin or increased free floating phenytoin in the blood, which will ultimately increase its action. So, this is how two drugs can affect each other at this phase, at distribution phase. And this is mainly significant for the drugs. Those have rapid distribution, or the drugs which has narrow therapeutic index, because if a drug goes and displaces a protein bound drug, and if that component or compound has a low therapeutic index, then this sudden increase in plasma concentration will lead to severe side effect or can be lethal also. And the example for drugs which has a narrow therapeutic index are lithium and digoxin. So this is an example how during the distribution phase there can be drug interaction. The third and the final phase drug goes through is the excretion. So excretion also is affected by uh, different drugs. How it can be get affected? So any drug that increases the GFR, the glomerular filtration rate, can affect the excretion of the drugs that is present in the blood. So drug which decreases GFR is going to increase the plasma concentration of other drugs, like in general. So output is decreased, so the drug that is free floating in the blood or present in the blood is going to stay in the body only. And here, I would like to quote one example which we will see in drug interaction specifically. So, this is one thing that the filtration rate is changed. But there is another factor here. So, this is a nephron, a very bad nephron. So, these nephrons, they have certain channels here. That is why they do absorption and excretion. So, certain compounds, they have affinity towards these transporters. So, some interactions are due to this competitive binding to these tubular transport system. An example I would like to quote here is methotrexate and NSAIDs. We will see this again. So, methotrexate excretion is inhibited when these patients take NSAIDs. Why is that? So, this compound, for example, needs to be excreted out by this transporter. But NSAID, when present in uh, the filtrate here, it has a tendency to occupy all these transporter. And when NSAIDs are occupying these transporters, then methotrexate won't be able to go out of the tubules and it stays in the body. So this is a competitive type of occupancy of the tubular transport system. So this is how they can affect. So during excretion phase, they can affect the GFR in general, or they can competitively occupy the transport or the gates from which the other drugs are going. So is this clear so far, or you want me to repeat anything here? Okay. S- Hello, doctor. How are
Hi,
you?
doctor. I'm good. How are you?
I'm curious to know, why did you say all senses are working?
When you were asking, am I able to, you are guys able to hear me or see the screen? So
Oh, okay,
yeah.
okay. You know, in last class you said you were on meds, or I don't know what we were discussing, CNS medications. So I thought you were
Yeah.
joking then, so that's why I asked if it is a joke or you were serious.
So my jokes are so
No,
bad.
no, no,
You guys
no,
don't
no, no,
understand.
no. It's my bad.
It's okay. No, it's fine.
Okay.
I just want to know about
Yes,
gastric
please.
emptying and
Okay.
absorption. Yeah.
So this is a tubule, and the rate of flow of water here is 10 nautical miles per hour, for example, or say that's actually a big number. Rate of flow is 10 liters per minute. Okay, so
Okay.
the time for absorption of the components in this fluid is a, let's take it is x seconds it requires to absorb from this speed. And now the same tubule,
Okay.
we double the flow of rate, and it is 20 liters per minute. So do you think it's going to affect the rate of absorption? So this is
Yeah.
less, exactly.
Absorption will be
Absorption will
less.
be less. Most of the compounds will just
Okay.
go and flush out. So this is how
Okay.
gastric
Okay. Now I
emptying is
got it.
affecting. Um, Like cholinergic drugs, if they are affecting the constriction of or the smooth muscles in GI tract, they're going to affect the absorption of not only drugs but
Okay.
other components also. That's why in patients with diarrhea, no matter what they eat, they stay malnourished at that moment, because the gastric emptying is so fast that the body is not able to absorb anything,
Okay.
nutrients and drugs.
Okay. Okay. So body is not able to,
Yeah, you can say that.
match up the speed
Yes,
with the flow. Okay.
no
Okay.
problem, doctor.
Thank you.
The reason why I included this part was when I was studying drug interactions. So, when I only studied before inducers and inhibitors, but few interaction didn't make sense to me. So when I looked online and I checked that there are interactions happening at different levels, and that's irrespective of their metabolism in the liver, certain drugs were affected by presence of few other drugs. That's why I mentioned here that there are other factors also, not just cytochrome P450, but there are other factors too that causes the interaction. And interaction can be anything.
Okay.
I mean, it could be positive, negative, or it could be just change in the rate or change in the concentration without any effect.
Okay.
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 Okay. So
Thank
no
you.
problem, doctor. So we discussed absorption, excretion, and distribution part, and this is all under kinetics. Now coming on to the main thing, the metabolism. Most of the substances that we eat, other than the nutrients, they go and get metabolized in the liver. So in the liver, there are certain groups of soldiers that are there to fight the toxic substance or detoxify the substance that we are eating. And these group of enzymes or group of soldiers are called as cytochrome P450. What are these actually? Cytochrome P450, they are membrane bound enzymes. And when we say membrane bound enzymes, they are similar to the receptors. So, as a structure, this is the cell membrane, and here we are talking about cells that are present in the liver. So, hepatocytes, these are the cells, and on their membrane, there are certain enzymes that are bound here. So, they are present on the receptors, and they have a helix that keeps it bound to the membrane, and there is this part. So, this um, cytochrome P450, is it lagging for only me, or you all can feel the lag? Not sure what is happening. So, the cytochrome P450, it's a broad term of large family of enzymes that are present on the surface of the hepatocytes. So they are membrane bound enzymes, and they are named so because when we say cyto means, and chrome means heme, the color. So these enzymes, they actually have a core of heme molecule. All the cytochromes, like RBC, they have heme molecule. That is why they are called as cytochrome. And P450 means, so P is for pigment, so heme pigment. And 450 is actually given, this number is given because these enzymes, they have the capacity of absorbing the light of 450 nanometers. So this is why they are called as cytochrome P450. It's a broad broad term for various enzymes. So cytochrome P450 is like these membrane bound enzymes. So this is P450 and it has some subunits attached to it. And these subunits are also named. So, like cytochrome P450 is the main uh, uh, name or the main family. And then, for example, let's take 1A2. So, 1 means this part and A2 means this part. So, they are subclassifying these cytochrome P450 molecules. And most of the drug interactions are because of the action of this. So, this enzyme is responsible for um, converting the drugs into their metabolites. And when there is excessive activity of this enzyme, there is excessive metabolism of drug. When there is less activity of this enzyme, there will be less metabolism of the drug. So let's take an analogy here. So this is the cell membrane or this is the border and here are the soldiers, active soldiers. So for example, in a normal liver, and it is different in every individual. The number of active cytochrome 50 is different in every individual. So here we have 5 active soldiers and 5 dormant soldiers. This is a normal condition. So there are few drugs that act as inducers, not just drugs, compounds. They act as inducers and some act as inhibitors. When we say inducers, what are they doing actually? They are activating all the cytochrome P450s. So more soldiers are here to fight now. And they're gonna act, their action is enhanced. So here 5 were fighting and now we have 10. And on the other hand, when inhibitors we talk about, it is doing the opposite. It is making more cytochrome P450 dormant. So the metabolism will be less. In general, if we say the inducers agent, they are going to decrease the plasma concentration of drug. And how are they doing it? Because they are eating up all the drug molecules that are there. Here in a normal condition, they will.
Excuse me, Dr. Tanvi. Sorry
No,
for
no problem at all.
interrupting you.
Yes, please.
Your screen is gone.
Oh, really?
Yeah.
Can we ever have a flawless class? Something or the other
I guess
happens.
they are against free sections, you know. They want us to pay money and take the,
Yeah,
paid classes.
that's right.
They are the tricks.
You're right.
Yeah.
But I think we still try to find things for free. Okay,
Yeah.
can you see it now?
Yeah. Now it's fine.
Okay. So should I repeat this part?
I guess this is clear, and you are on the other screen.
No, I was on this only. So okay,
Yeah.
good. So here in a normal state, they were metabolizing 5 molecules, and as there are more soldiers available here, they will metabolize 10 molecules, and the effective plasma concentration of the drug would be less. And on the other hand, when there is inhibitors, they're in the blood, they are going to increase the plasma concentration because there are less cytochrome P450 to neutralize the drug compound. There is an exception here which I would like to mention, and the exception is prodrug. So it is simple to understand that inhibitors are going to increase the concentration because they're inhibiting the metabolism, or they're inhibiting the substances that are responsible for metabolism of the drugs. And inducers are going to increase the metabolism and therefore decreasing the plasma concentration. There are certain drugs that are given in an inactive form, and they are called as prodrug. They are like a precursor of the active compound. And when these compounds they reach liver, after their action or after the reaction with cytochrome P450, they become active. So after the reaction with the enzyme, they become active. So in this case, if there is an inducer that is increasing the metabolism in the liver, it will increase the active drug in plasma. And on the other hand, if there is presence of inhibitor, then the prodrug will not be activated. It will stay inactive only. So that means there is decreased active plasma concentration. So in this case, inhibitors are decreasing the plasma concentration and inducers are increasing the plasma concentration when we talk about prodrug or precursor of the drug or the drugs that are given in inactive form. And on the other hand, with most of the drug interactions, inducers are going to decrease the plasma concentration and inhibitors are going to increase the plasma concentration. There was one more thing that I wanted to mention and now I forgot. Hmm. Okay. Okay. Also, one more thing I would like to tell you guys here. So when we say inhibitors, these inhibitors they have rapid action because making something dormant is quicker. But when we have inducers, so these inducers they actually have to wake these up, these sleeping or dormant cytochromes. Actually, they need time, or these inducers they produce their inducing effect in few days because there is need of synthesis of more cytochromes. So the effect of inducers come after few days, but effects of inhibitors it is rapid. Oh yes, now I remember what I was telling you. So although it's not so important, but it will help us to understand. So cytochrome P450 enzymes are very basic type of enzyme, and what do? They are monooxidases. And when we say oxidases, that means they are playing with the oxygen molecule. Either they are adding the oxygen molecule. And when we say mono, so these cytochrome P450 they keep on playing with this single oxygen molecule, and this is how they detoxify. And there are further reactions also. And going back to the basic, there are two types of phases in the liver metabolism, phase 1 and phase 2. And the goal of both the phases is to make drug less polar or make drug more hydrophilic so that it can be excreted out via kidney. So phase 1 are so when the drug goes in phase 1 or it goes to liver, what it does, it tries to do basic types of reactions, and it could be oxidation, hydrolysis or reduction. And the goal of these reaction is to make the substance hydrophilic so that it can be excreted out via kidney. But certain substances, even after these simple reaction, they stay polar, and when they are polar or when they are lipophilic, the cells can take that compound again and get rid of those. So such compounds which are still if still lipophilic, they undergo phase 2 reaction. And in phase 2, the liver enzymes, they are adding up bigger molecules to this drug to make it more non-polar. And these bigger molecules are like glucuronidase and acetylation, sulfation. So these sulfation, acetylation, and glucuronidation, they are adding these like sulfur group or acetyl group and so on in order to make it bigger, like bulkier and hydrophilic. And when it is bulky and hydrophilic, it cannot enter the cell and there is no effect of the drug. And it when it is hydrophilic, it can be excreted out. So these are two phases of metabolism that is happening in the liver, and the main component of the enzyme that is causing these reaction is cytochrome P450 family of enzyme. Okay. So the substances that act as inducers and inhibitors are so inducers I remember as when on the beach I see crabs, I feel like running. So it induces the fear or it induces the feeling of moving away. So inducers are P crabs. And the drugs here are phenytoin, carbamazepine, rifampin. This is called as the mother of drug interactions in antibiotics because it reacts with most of the other agents, and it is used uh, only in cases of tuberculosis when it is when we have no other choice. Alcohol and chronic alcoholism causes or act as inducer. B for barbs and S is for smoking. And in inhibition, sitting on the couch and playing games is like inhibition only. So Pac-Man is a game. So G Pac-Man are the inhibitors. G is for grapefruit, protease inhibitors. Protease inhibitors, if you remember, it was in we studied this in antiviral, and anything that is eating up proteins, those enzymes are called protease. And these protease inhibitors was they were limiting the release of virus colonies, and these drugs are also uh, being used in COVID patients. A is for azoles, C cimetidine, very important, M macrolides, except azithromycin. Amiodarone, and N is for CCBs, non dihydropyridine CCBs, calcium channel blockers. And they are, if you remember, non hydropyridine CCBs, they were acting on both smooth muscles and heart, on the calcium channels, and the drugs under this are diltiazem and verapamil. And two more I would like to mention here: acute alcoholism and metronidazole. So these are the list of inducers and inhibitors. Inducers are going to increase the number of active cytochrome P450, which will increase the metabolism. And when the metabolism is high, the plasma concentration of active drug is going to decrease, excretion of drug will increase, and it's going to be opposite in case of pro drug. If the patient is taking pro drug with an inducer, the drug will metabolize into its active metabolism in higher concentration, and therefore the plasma concentration of the pro drug active component will be high. On the other hand, inhibitors are inhibiting the active cytochrome P450, therefore reducing the metabolism, and the active drug concentration is less in plasma. Is there anything that you want me to repeat so far?
Hi, doctor.
Hello, Dr. Marcel. How are you?
Hi, how are you?
I'm good
with you.
too. Thank you.
Great. So this is the same thinking that we talked about a while ago. So since CP450, it's a negative, it inhibits, and negative plus negative, it's a plus.
Yep.
Yeah, the end result would be increase amount, and negative plus positive, which is inhibitor, which is CP450 plus an inducer, will be a plus result, right?
Yes.
Okay. Okay.
I remember you. Now I remember you texted me this when we started pharmacology.
Yeah. Okay. I
Okay.
just wanted to make sure. Thank you.
Thank you. Thank you so much. Okay. So now let's talk about each categories of drugs that are involved in drug interactions. So the first class that we will discuss is anesthesia. Here we'll talk about two anesthetics that show some drug interaction. One is lidocaine, and lidocaine metabolism is mainly by cytochrome P450. So cytochrome shows interaction with two substances. One is another anesthetic, bupivacaine, and the other is tramadol. Which is an used for um, used as an analgesic, an opioid. And with bupivacaine, lidocaine shows additive effect. If you remember, this is a type of drug interaction that we see in pharmacodynamics. So these two local anesthetic product, they increase the effect, or they increase the anesthetic effect, and can lead to or poses a risk of CNS toxicity. With tramadol, it doesn't happen much, but it can lead to seizures, and this is mainly seen in elderly patients who already have seizures. So it is rare and can lead to increase frequency or intensity of seizures. And here bupivacaine and lidocaine, they show additive effect and may lead to CNS toxicity or increase the risk of CNS toxicity. On the other hand, the other anesthetic that shows the interaction is mepivacaine, and it is seen to interact with meperidine, another opioid. So, opioid leads to sedation, we know, and this sedative effect can increase the risk of uh, LA toxicity or mepivacaine toxicity. So, sedation caused by meperidine increases risk of toxicity. So, it is recommended to reduce the dose of anesthesia in both the interactions. The next class is sedatives. So, two categories of drugs that are under sedatives shows drug interactions. They are benzos and barbs. So, the main reason why barbs show drug interaction is because of their effect on cytochrome P450. And they enhances the metabolism, and as they are inducing the metabolism, the plasma concentration will be low. And the drugs that it shows interaction with are digoxin, thiophylline, anticoagulants, mainly oral anticoagulants, and corticosteroids. So they enhances the metabolism, therefore they reduce the uh, plasma concentration of these drugs. And if patient is on anticoagulants and has any heart condition, and barbs were given which decreases the level of anticoagulants, the patient is at higher risk of heart attack or any ischemic attack. And it also interacts with benzos and alcohol and antihistaminics. And it is like an additive effect, antihistaminics. So here it is increasing the metabolism, and with these drugs, barbs show additive effect, and which can increase the risk of respiratory depression because they are acting in CNS. Additive effect can lead to CNS depression or respiratory depression or sedation. So these are two reasons why barbs act with other or interact with other drugs. On the other hand, benzos, they interact with drugs like digoxin again. Digoxin and warfarin, they have interaction with so many drugs, so we will see that separately also. Again, thiophylline, cimetidine, oral contraceptives, azoles, barbs, and alcohol we discussed here already. What else? Protease inhibitors. Protease inhibitors are on the other side, they are inhibitors for cytochrome P450. So these category of drug, they are decreasing the metabolism of benzos itself. So they are, when given with these drugs, they increase the levels of benzos, and when benzos stay active in plasma, can lead to excessive sedation than the predicted requirement. And also digoxin and phenytoin also here, their levels are also increased when given with benzos. So their serum concentration, it can be increased and can lead to toxic effect. So they are increasing the benzos concentration, therefore increasing the chances of sedation. And also digoxin and phenytoin concentration can also stay higher in the blood. When we talk about protease inhibitors, they increase the bioavailability of protease inhibitors is higher when it is given with benzos, and it is seen mainly with triazolam. I'm not sure if this is important to remember, but they all are actually increasing the effect of benzos directly or indirectly, and therefore more sedation is there. So these are the interactions seen with sedatives, with barbs and benzos. So we are left with analgesics, epinephrine, and what else? Antibiotics, and some common interactions. So if you guys do not mind, can we do these for tomorrow? I had no chance to read it, and I don't think I should be going over these without uh, reading before the class.
Hi, Dr. Tanvi.
Yes, Dr. Kiran.
Yeah. I have a doubt. In
Yes,
acute,
please.
that acute alcoholism is inhibitor, right?
Yes,
And what about chronic alcoholism?
that's the inducer.
Okay,
Yes,
that's why I was confusing. Okay, okay. Thank you.
no problem. Hello, Dr. Anya. You are early for tomorrow's session.
Yeah, exactly. Yeah, we're so no, I was so ready for the lecture, but just something came out, so I couldn't join.
Okay. No problem. I was thinking with I was discussing with Dr. Lisa today if um, everything permits, then I don't mind repeating drug interactions on maybe on weekends.
Okay, it will
Maybe
be great.
1 hour.
This will
Yeah,
be great. Yeah, thank you.
no problem.
And I just want
Yes,
to
please.
tell you something. And some of the friends that they are taking the course now,
Okay.
he just sent me tables. He said Dr. Maran shared something adding to the book.
Okay.
I will send it to you. I didn't like
Oh,
study
thank you
the drug
so much.
interaction well. Just check if there is any change.
Okay, yes,
Because
I'll
I
review.
couldn't like I didn't finish
Yes.
pharma, so I don't know how to. Okay,
Oh,
I'll share it with you.
no problem. Thank you so much for this.
Don't worry. Yeah, okay. Have a good night. Thank you.
You too, please. Thanks.
Hello.
Hello. Hi, Dr. Divya. How are you?
I'm good. Anvi, how are you?
I'm good too. Thank you.
It's a kind of a personal question, if you don't mind.
I don't mind, but you know, right? We have other 26 people here. So if you don't mind asking, I'm okay.
Okay. That's absolutely fine. I'll ask you personally then. Hello.
Yeah, I'll wait for your message then.
Okay. Bye bye.
Okay. Thank you, Dr. Divya. People are curious now. Either you have to tell them what the question is or make a story.